Regulation of blood pressure is a vital physiological process, enabling the body to respond to immediately changing demands, such as fight or flight or resting. This Nursing Times peer-reviewed article explains orthostatic hypertension and covers the anatomy, physiology, and regulation of blood pressure, and is read to you using an automated voice. The authors are Mike Lowry, former lead for clinical skills and simulation, School of Nursing and Healthcare, University of Bradford; Julie Windsor, patient safety clinical lead, medical specialties, older people, NHS England; Sarah Ashelford, former lecturer in biosciences, the School of Nursing, University of Bradford; Dr. Julie Whitney, consultant practitioner in gerontology, King's College Hospital, and lecturer in physiotherapy, King's College London; Dr. Sarah Howie, consultant geriatrician, St George's Hospital. For full citation and references, visit nursingtimes.net, where the article can be found under the topic of assessment skills, or search for Nursing Times, the anatomy, physiology, and regulation of blood pressure. Abstract. In response to certain situations, a series of actions take place in the body that can either raise or lower blood pressure. It is vital that nurses understand these actions and why they take place. Introduction. In healthy people, each heartbeat forms a pressure wave that travels down the arterial system. The peak of the wave occurs during systole when blood is under pressure from cardiac contraction, making the arterial wall expand. During diastole, when the heart is briefly relaxing, the arterial walls recoil, delivering a pulse. Systemic circulation provides oxygenated blood to all cells in the body. It is essential that this blood supply is always maintained. After perfusing the organs, blood is returned to the right atrium of the heart through the systemic venous system. Blood pressure regulation. Blood pressure is the result of cardiac output, the volume of blood that is pumped out of the left ventricle per minute; systemic vascular resistance, the total resistance opposing blood flow within the systemic circulation. Cardiac output is a major factor determining BP. However, as blood flows into the arterial system, it meets resistance, in the form of friction, from contact with blood vessel walls. The main resistance to blood flow occurs in the arterioles, which are smaller vessels formed from the branching of arteries. They are referred to as resistance vessels. Resistance from all blood vessels in the systemic circuit combines to produce the systemic vascular resistance, which increases BP in the systemic arterial system. These two factors together, cardiac output and the systemic vascular resistance, generate actual BP in the systemic arterial system. BP adapts according to altered needs. For example, when an increase is needed due to altered demands, such as in a fight or flight response, BP increases quickly until either the demand changes or needs for increased pressure are fully met. Conversely, when less pressure is needed to ensure adequate supply of blood, for example, at rest, BP reduces to its normal resting value. These rapid short-term adjustments to BP are controlled by the autonomic nervous system through the baroreceptor reflex. Role of autonomic nervous system. Cardiac output and systemic vascular resistance are adjusted on a moment-by-moment basis to ensure BP meets the body's needs. Cardiac output is determined by the heart rate, the number of heartbeats per minute, multiplied by the stroke volume, the volume of blood in milliliters, pumped out with each heartbeat. The heart has a dual nerve supply from the two branches of the autonomic nervous system, sympathetic and parasympathetic, which regulates both the heart rate and stroke volume, and as a result, cardiac output and BP. Increasing sympathetic stimulation to the heart increases the heart rate and the force with which it contracts. Up to a certain point, this leads to an increase in stroke volume, producing an increase in cardiac output. If the heart rate exceeds a particular threshold, inadequate time for the ventricles to fill can result in a lower stroke volume. The same increase in heart rate and force of contraction occurs in response to increased levels of the hormones noradrenaline and adrenaline released by the kidneys. These effects occur, for example, during exercise or a fight or flight response. The force with which the heart contracts also depends on the volume of blood returning to it. Decreases in heart rate occur through decreasing sympathetic activity and reductions in circulating levels of adrenaline. Increasing the parasympathetic stimulation to the heart reduces the heart rate. The sympathetic and parasympathetic actions oppose each other and allow the heart rate to be fine-tuned. Vasoconstriction. The main factor influencing systemic vascular resistance is the diameter of the arterioles, which are supplied with sympathetic nerve fibers that, when stimulated, cause the smooth muscle in the wall of the arterioles to contract. Contraction of the smooth muscle causes the arterioles to constrict. This is vasoconstriction, which increases the resistance to the flow of blood and therefore increases systemic vascular resistance. It is an important way of increasing BP and, again, will occur during exercise, illness, or a fight or flight response, when increased BP is needed. Role of venous return. The volume of blood returning to the heart is called venous return. If this increases, more blood returns to the heart, stretching the myocardium, muscle making up the wall of the heart. Up to a certain point, the more the myocardium is stretched, the more forcefully it contracts. An increase in venous return causes an increase in stroke volume and cardiac output. Increases in venous return are important during exercise when skeletal muscles contract more often and forcefully. This squeezes blood in the veins and results in a greater volume of blood returning to the heart. In contrast, if there is loss of blood through hemorrhage, it will result in decreased blood volume and a decrease in venous return. This is why BP drops after significant blood loss. Understanding the physiology underlying BP is vital to understanding the baroreceptor reflex and its importance in BP control. The baroreceptor reflex. This is an autonomic reflex that acts to maintain BP in the short term, and particularly in response to changes in posture, such as when moving from sitting or lying down to standing, when gravity can cause BP to fall. The baroreceptors are receptors located in the walls of the arteries at the carotid sinus and aortic arch. They act as pressure sensors, detecting changes in arterial BP through the stretch of the arterial wall. When BP rises, arterial walls are stretched more, and the baroreceptors are stimulated to fire more frequently. If BP drops, the stretch of the arterial walls decreases and the baroreceptors fire less frequently. Nerve impulses pass from the baroreceptors to the medulla in the brainstem, where nerve centers regulate the activity of the sympathetic and parasympathetic nerves. A sudden decrease in arterial pressure will decrease baroreceptor firing, increase the sympathetic outflow, and decrease the parasympathetic outflow. These changes will cause vasoconstriction of the arteries and arterioles, which increases systemic vascular resistance. Sympathetic outflow to the heart causes an increase in heart rate and force of contraction, increasing cardiac output. Increased systemic vascular resistance and increased cardiac output together raise the BP. In contrast, if the BP increases, the baroreceptors will be stimulated to fire more frequently. The medulla will respond by increasing parasympathetic output and decreasing the sympathetic output. This will result in decreased cardiac output and systemic vascular resistance, and thus a drop in BP. The following are clinically relevant situations in which the baroreceptor reflex may be compromised. Orthostatic hypotension. Orthostatic hypotension occurs when there is a sudden drop in BP due to a change in a person's position. On moving from sitting to standing, or from lying down to standing, gravity acts on the vascular system to reduce the volume of blood returning to the heart, and around 500 milliliters of blood can pool in the legs and lower extremities. This drop can be particularly marked when moving from lying down to standing and can increase the risk of falls, which is explained in the second article in this series. The lower venous return reduces the volume of blood that is available to pump out of the heart, which causes a drop in cardiac output and a momentary drop in BP. At this point, the normal response would be an increase in heart rate to increase cardiac output. If there is no corresponding increase in heart rate, this could be a sign of autonomic dysfunction. Reduced blood volume. Blood loss, hemorrhage, leads to lowered blood volume, which in turn reduces venous return and pressure, leading to hypotension. Dehydration due to reduced fluid intake, increased fluid output, or infections and medication, such as diuretics, will also reduce blood volume. Carotid sinus hypersensitivity. Carotid sinus hypersensitivity is an exaggerated response to carotid sinus baroreceptor stimulation in the neck, resulting in dizziness, falls, and/or syncope from transient diminished cerebral perfusion. Characterized by a sudden drop in BP and/or pulse, ventricular pauses of more than 3 seconds, and/or fall in systolic BP of greater than 50 millimeters of mercury. Typical triggers include shaving, turning the head, extending the neck, and wearing clothing with a collar that is tight. Postprandial hypertension. Postprandial hypertension, or low BP after eating a meal, is commonly defined as a decrease in systolic BP of greater than or equal to 20 millimeters of mercury and observed within 2 hours after the meal has been ingested. This can occur because eating diverts blood to the stomach and intestines to help with digestion, which in turn reduces venous return, as well as stroke volume and cardiac output, and lowers BP. Along with orthostatic hypertension, postprandial hypertension can often occur in healthy people. Usually there are very modest drops in BP and no symptoms. In older adults, especially those with reduced autonomic and baroreceptor responses, this may cause falls, syncope, dizziness, and fatigue. Patients with confirmed postprandial hypertension should eat small, frequent meals that are light in carbohydrates. These patients may also need extra support after meals to ensure they mobilize safely. Given the potential prevalence of this condition among hospital inpatients, nurses should review and consider the timing of routine observation rounds, which typically occur within 2 hours of mealtimes. Valsalva reflex. The Valsalva reflex, or Valsalva maneuver, is a sudden rise then drop in BP that occurs when a person strains to open their bowels. It can occasionally lead to vasovagal syncope, fainting. When an individual is straining, exhalation with a closed mouth, nose, or glottis occurs, which increases pressure in the chest cavity. This increase in thoracic pressure decreases venous return, which can decrease cardiac output and therefore BP, leading to collapse. An analysis of a random sample of 200 falls reported to the National Reporting and Learning System showed that 15% occurred while the patient was using the toilet or commode. Although it is reasonable to assume that most of these falls occurred while the patient was trying to attend to personal hygiene, nurses need to be mindful of the potential for vasovagal episodes in these circumstances. Conclusion. BP is a vital bodily function, and nurses need to understand its anatomy and physiology to be able to assess the risks of it becoming too high, too low, or dropping when standing, and then to take the necessary precautions to reduce risk of harm to the patient. The full version of this article with references and illustrations can be found at nursingtimes.net under the Assessment Skills category, along with the second article in the series which looks at how orthostatic hypotension is linked to falls, why it occurs, who is at risk, and how it can be identified and managed. Thank you for listening.